So hello everyone and welcome to this case discussion series, case 18. It's a very interesting case. So we have a 27-year-old female who presented with pain in the left upper thigh and low backache since 1 month, and we have X-ray pelvis AP view of this patient here, where we can see a well-defined lytic lesion in the left iliac bone with a narrow zone of transition. So this is the MRI picture of the same patient. These are the axial sections, T2 weighted images, where we can see that this well-defined exophytic cystic lesion arising from the iliac bone, displacing the iliacus muscle medially with multiple fluid levels on T2 weighted images. These are the T1 post-contrast images, where we can see that there is some subtle peripheral enhancement. These are the coronal T2 weighted images, where we can see fluid levels and the lesion arising from the left iliac bone. Again, the coronal images, where we can see that cystic lesion with multiple fluid levels arising from the left iliac bone.
T1 दे दें sir.
These are the T1 coronal images. Some hyperintense signal is also seen.
Contrast दे दें sir.
These are the T1 post-contrast coronal images. Here we can see that there is a peripheral enhancement and also some edema in the surrounding bone, iliac bone. These are the SAG images, post-contrast. So this is a report that I had given, that the study showed a large exophytic multiloculated cystic mass lesion arising from the left iliac bone and displacing the left iliacus muscle medially. The extraskeletal part of the lesion measured 38 into 66 into 79 mm and exhibits multiple fluid levels on T2 weighted images, which is characteristic of an aneurysmal bone cyst, and appears iso to hyperintense on T1 weighted images. That depends on the stage at which the blood components are. And there was mild peripheral post-contrast enhancement with diffuse edematous changes in the ipsilateral iliac bone as well as the adjacent part of the iliacus muscle. There was no evident enhancing soft tissue component which was present in the lesion. This is very important because this helped us differentiate it from a giant cell tumor. So this particular finding was suggestive of a predominantly extraskeletal aneurysmal bone cyst arising from the left iliac bone, but the possibility of a locally aggressive giant cell tumor could not be completely ruled out. There was no evident pelvic lymphadenopathy that was seen. So the patient was advised injection denosumab 2 doses 15 days apart for 1 month, and this is post denosumab. So usually denosumab study has been done for giant cell tumors only. Denosumab is not FDA approved for aneurysmal bone cyst, but it has proven to be beneficial in aneurysmal bone cyst because of the same pathophysiology. So this was post denosumab injection 2 doses, where we can see that there is decrease in the fluid levels and there is a layer of calcification that is seen around the lesion. There is of course a lytic lesion, the lysis of the iliac bone that was seen, indicating its origin from the left iliac bone. But definitely post denosumab there was decrease in the fluid levels and there was a thick calcific rim which was present around the lesion. This was advised by the surgeon before the surgery so that the lesion could be well delineated and could be easily resected. So how do we differentiate a giant cell tumor from an aneurysmal bone cyst? The features on MRI include hemorrhagic areas which are seen in both. Fluid levels are also seen in both. Surrounding edema was also seen in this particular case. But the soft tissue extension and the soft tissue components are particularly seen in a giant cell tumor, which is not seen in an aneurysmal bone cyst. So the histopath came and it was an aneurysmal bone cyst.